Dr. Killian is the co-founder and executive director of Paraclete Care, LLC. He's a licensed psychologist in Minnesota and a certified clinical trauma professional. He's also a professional member of the International Association of Trauma Professionals. In addition, he's a member of the Christian Association of Psychological Studies and a member of MAC. He also serves on the MAC board. Marcus enjoys teaching graduate counseling courses online at Liberty University, where he currently serves as an assistant professor. He's had training and clinical experiences in different professional contexts, such as hospitals, Christian counseling centers, outpatient mental health clinics, correctional institutions, sex offender treatment clinics, and residential drug and alcohol treatment facilities. Marcus is passionate about integrating his Christian faith with research-based counseling approaches and views Christian counseling as a way to promote spiritual formation for clients. Welcome, Marcus.
Thank you so much for having me. Before I get started, let me just go about a background here. I worked in prisons in Wisconsin and Minnesota, and I didn't choose to focus on trauma, but the clientele, as you know, is very traumatized, the prison population, and so I was thrown into the trauma work, and so yeah, and then basically based on my work in prison, I also then developed the other specialty in sex addiction because of sex offender treatment and psychosexual evaluations I had to do. So this is not by choice. So today we will talk about, those are our objectives. We will define simple and complex trauma. We'll provide an overview of the 3 treatment phases of trauma and discuss at length the phase 3, consolidation and reconnection, and discuss how to help clients improve and develop relationships to others and God. So just to provide this overview here. Again, I'm not going there in detail. So this is the PTSD criteria from DSM-5. Against intrusive symptoms, avoidance, negative alterations of thoughts and moods, and alterations of arousal. I don't want to kind of go there because you can read it yourself, DSM-5. And as pastors, you can Google it. Now you can Google everything, great. So, but again, also if you choose to email me, you can also read it then. But this one, we will talk more about it. This is by Herman. And so if you're going to want to read a good book about trauma, this would be a good book to start reading. I know it's dated, but it's still a classic in the field. It's Trauma and Recovery by Judith Herman. And she talked about complex traumatic stress. And she wanted to propose this, or I think she tried to propose it to the DSM-5 task force to have it included in the DSM back then, maybe 3 or 4 or so. I think it was 3 or so, but they turned it down. But I think it's still a good guide for us to conceptualize complex trauma. And so, and you will see various disorders in there, in this description. The first one is alterations in affect regulation. So we can see PTSD in there, right? So this is similar. Alterations in attention and consciousness. Also, again, this is similar to PTSD in a somatization. Oftentimes there's chronic pain associated with traumatic stress. Digestive system, especially since we bear our trauma in our stomach, right? So oftentimes people get stomach ulcers, right? They, stomach upset, you have to eat Tums, whatever. So, and so there's no wonder that you develop a digestive system problem. Then oftentimes, this is my hypothesis, I don't have any research to back it up, but fibromyalgia, oftentimes some people say it's also based on trauma, into the chronic pain. But then some say it's based on a lack of sleep or reduced sleep, which could also be based on trauma when you think about it, because oftentimes people with a traumatic background, they don't sleep very well and wake up early or too often throughout the night, which can then secondarily affect the development of fibromyalgia. But I want to focus on those the last 4, because they directly relate to our phase 3 work. And the first one, alterations in self-perception. So this is chronic guilt, shame, self-blame, minimizing traumatic events, feeling that one is permanently damaged. This is what we talked about this morning, or somebody mentioned it. I think Hector mentioned it. that you feel like you're worthless. And you can imagine if it's like a simple PTSD, it may not affect your self-esteem again because you have a good attachment system. You have loving parents, loving grandparents who have supported you. But if you never had this, and you're exposed to traumatic events, then your self-esteem gets a hit. And and this affects your interpersonal functioning later and affects your reintegration in the community later. Alterations in perception of the perpetrator, idolizing, or preoccupation with hurting the perpetrator. So this is the chronic anger or rage that we often see in borderline personality disorder, oftentimes maybe, PTSD as well, other trauma-related disorders. And again, this also has a direct implication for our phase 3 work to help those clients to be connected to a community. Alterations in relations to others, problems with trust, re-victimization of the self, victimizing others. And then the last one, alterations in systems of meaning, despair, hopelessness, loss of faith. Berman's not a Christian, but we could add to this God image. Tim mentioned this morning, the God image is often harsh and maybe not so much based, and this is my opinion, don't have to agree with me, maybe not so much based on the abuse itself, but the attachment that provides the context for the abuse to occur. But we'll go to this later. Any questions?
But how many people do you think actually get help for things like this? I see so many people.
I don't have statistics there, maybe somebody can jump in. I don't think that everybody, definitely not everybody, and my assumption is, especially in rural areas, there's almost no help there. I think, I mean, the Twin Cities were pretty well,
Because their life becomes normal, it's
exactly.
normal to them.
Exactly. And again, we also talk about this later, then if they select a partner, it creates this interpersonal puzzle piece. They select a partner that kind of, like Tim talks about looping, it kind of continually, continues the attachment pattern and potentially also traumatic pattern of abuse, right? And so this is then normal. Because if you're raised in this condition or based on those attachment conditions, then your normal is basically to look for husbands or wives who are similar to your dad or mom. And if you don't have the insight to change it, then you just continue this pattern. So there's definitely, in the Twin Cities, I'm assuming people, especially in Christian circles, I'm assuming that maybe wrongly assume, that the pastors, the small group ministries, that they maybe say, oh, do you really need counseling? Have you considered, oh no, I don't need counseling, But maybe through faith, they may be encouraged to seek counseling more than non-Christians. And that's just my assumption. Does anybody have maybe some feedback or some answer for that? How many people are being helped?
I don't have statistics on how many are being helped, but I do have statistics at home on the base rate populations of complex trauma, people that are endorsing more than 4 ACEs, and they've narrowed that down to different groups. So like kids living in 2-parent homes, kids living in split homes, kids living in urban areas, kids in rural areas. I've seen those for kids. I don't know. I'm sure they're out there based on the ACEs and stuff like that. But then how many get treatment?
Yes.
Then how many get treatment? Because ACE studies done a whole lot with giving us base rates, but not a lot for how many seek treatment. I don't know that I can get that's out.
And I'm sure there is a large, we can only study people who come to the office.
Yeah.
So we can't study everybody who lives in the community, and so it may be underreported, right? So, so if there are no other questions about this, let's go to this. Maybe some of you have seen this too. I like this kind of polyvagal theory, and it helps us conceptualize what the client needs. And based on this, we have the optimal level of functioning here. And this is like someone who's securely attached, not traumatized, no bear coming after him, or a wolf in the woods somewhere. So this is like, you're pretty relaxed, and you can engage with others. You can think clearly because your fight and flight limbic system is not activated. But then our traumatized clientele, they are often either here or here. So it doesn't work this way. So they're either over-aroused, hyper-aroused, or they are hypo, under-aroused. And oftentimes, the simple PTSD, we see the over-aroused type. They're like, can't sleep, they're agitated, they look like an ADHD client. So therefore, the rule out is this person ADHD, or is it like a traumatic complex, is it basically based on complex trauma, which we have to figure out, right? So they can be very over-aroused. Or after so many traumatic events, this person can dissociate. And this is basically when we're at the under-aroused, and then the parasympathetic nervous system kicks in, and no longer the sympathetic nervous system, and it's basically a more severe stress response. And this is what animals do when they play dead. Like a little squirrel, a little dog comes and whir, and they may just play dead, right? And this is like they're frozen. And sometimes, my wife or we said, oh my goodness, I couldn't move. I feel like this is like frozen, right? Something jumped in front of her car or something. This is the parasympathetic nervous system causes immobilization, and this is the oftentimes dissociation. So oftentimes traumatized clients may look very blunt. I don't have any flashbacks. I'm fine. Oh God, Jesus saved me. I'm fine. No, nothing's wrong with me. I'm fine. They'll be flat. Nothing can excite them. They may be on the under-aroused. And so examples, under-aroused, dissociation, and Gingrich, Tim mentioned this morning, conceptualized it on a continuum from normal consciousness. We all have daydreamed or are daydreaming, like when we think of, oh my goodness, this cookie was great. By the way, the cookies were awesome. This is my little ADHD moment right now. Automatic pilot while driving. Nobody just drives home and says, you know what, now I put the blinker on and go drive right and I go left. No, you do it automatic pilot. This is a simple form of dissociation. So this is the simplest form. Then you have dissociative episodes, can be religious experiences, and I mean it in a good way, when you feel like really close to God, meditation, Christian meditation, brief zoning out, can be borderline personality disorder. They have dissociative episodes where they kind of leave consciousness for a while. So this is part of it too. Then we have PTSD, flashbacks. Hector mentioned this morning when he was almost shot in St. Paul. He was in a kind of extended dissociative episode, right? And so then flashbacks, numbness, detachment, derealization, depersonalization, amnesia, and so on. Then we have dissociative amnesia disorder, depersonalization, derealization disorder, and then the more severe dissociative identity disorder when you have various ego states and alters. Over-aroused, and I don't want to go over there in detail, is like borderline personality disorder is a good example in my opinion. When all of you have maybe seen borderline personality disorders in your practice, and wide mood swings, again with asterisks, is best to illustrate the over-arousal. Short but intense episodes of anxiety, depression. I feel like killing myself, and then I'm fine, let's eat a sandwich. Right? So this is really and then oftentimes looking at bipolar 2, whatever, but again, this may be their personality, right? Inappropriate anger, antagonistic behavior, sometimes escalating into physical fights, difficulty controlling emotions, and feelings of self-hate, self-loathing. You see the over-arousal here. And now, before we go to attachment style, does anybody have a question about this way of conceptualizing the under-arousal or over-arousal before we go to attachment style? Go ahead.
Is there a criteria available to look at the differences between, say, a psychiatric disorder, something related to post-traumatic stress, or the impact of extended drug use on dopamine and some of the other neurotransmitters? How do you tell which is which?
That's a good point. So I think feel free to jump in, clinicians. the rule of, and Tim definitely, your expertise in substance abuse, if there's any drugs in the system, we would be very cautious to diagnose anything. We make sure that the drugs are out first. Would you agree, Tim, with that? And because the psychostimulants can look like a bipolar person, right? You have the excess of dopamine, then seeing things, having psychotic experiences, it can look like a schizophrenic person even. So we cannot, the person has to be stable and has to be clean, and the drugs have to be out of the system in order to diagnose. Did you answer your question?
Yeah,
Yes.
helpful.
And so definitely I would be very cautious to jump, to prematurely diagnosing those disorders. But the assumption is, since I think Paul mentioned too, that oftentimes the substance abuse population is often traumatized. So there's a good chance that there's this going on, but you just can't formally diagnose it unless you know for sure. Any other questions before we go to attachment style and briefly review attachment styles? Good. So let's talk about attachment style. The reason why I included this, because in order to, and this is just my opinion, in order to talk about complex trauma, we need to also talk about attachment style. Daniel Siegel, in his work on interpersonal neurology, he focuses on attachment style because he talks about him and Ellen Shore. We'll see some quotes by Ellen Shore later too. They're talking about the attachment trauma, the insecure attachment that causes shame, that causes a shock in the baby. Because every baby wants to be mirrored to, right? You're holding it, but what if the baby looks at the mom and the mom looks depressed? And have you maybe, Spitzer did like studies back then of babies who looked at the mom and the mom was depressed and the baby tried to get a good response and then it started crying too. That's what he said, right? So and this is basically the way that insecure attachment works, right? So the mother or the father is not available, and we'll go there. And we have 3 different attachment styles that are insecure, avoidant. So, and this was based on the strange experience by Ainsworth. And what she did, she had the kids separate from the mom, and then had the mom be reunited with the child. And upon reunification with the mom, those who were securely attached, they want to cling to the mother. Those who were avoidantly attached, they ignored the mother and said, "Oh, I don't know her. Who's she? Let's give me some candy." Right? So no attachment. And then you had the ambivalent, resistant children, and they were kind of little, they were a little confused. They're like, I don't know. Do you think if I go there now, will she support me or not? Or I'm not sure. So they're kind of a little confused and resisted later. And then later, Maine and Solomon was actually the mentor for Siegel when he did his doctorate, his psychiatry training there. She came up with Maine and Solomon, the 4th attachment style, the disorganized, disoriented one. It's the most severe kind. And oftentimes people see this as borderline personality disorder, by the way, because people already they don't have any consistent attachment strategy on how to relate to others. And because those attachment styles, they are templates how we relate to our later romantic partners, our employers, God, we'll talk about later.
Marcus?
Yep.
Question.
Yep.
I was wondering, what does it do, this all talks about the mother, if let's say the attachment to the mother is good, but then the father figure is terrible, or,
I know this was just the start, the study was based on the mother, but attachment is just as important to the father. And so oftentimes when we talk about attachment with the client, I often explore, so how was your relation to your mother and to your father? What about your grandparents? Were you close to anybody? And so it could be, oh no, I wasn't close to my mother, she was on drugs, and my dad he was absent, but I was super close to my grandmother. And she picked me up, and she spent time with me. Then wow, there's an attachment figure. It doesn't have to be the mother, it can be but if somebody, I wasn't close to my grandparents never met, my parents were on math, and I was raised by the state, basically. That looks like really bad. And so, right? So in the fourth attachment style, the child was confused, more confused than number 3, and fearful toward the mother. So you can see that the mother was abusive to the child, and yeah, and so kind of was not. And oftentimes, how they are created, those insecure attachment styles. The secure attachment style is they're sensitive to parents and responsive. And of course, I always tell clients, you know, we're all broken. There's no perfect family, right? But overall, Winnicott, the object relations, they talk about good enough mothering, right? Maybe some of you are, and I think good enough mothering would this be. So about 2/3 of children are securely attached. 2/3. The rest are insecurely attached. And this is what we see. We see basically about 5 to 15% of people, of the population, they need help from mental illness. And partly, it's my bias, it's because of the attachment style. So the first case, secure attachment, they can connect and explore, you know? So, oh, here, child, here's, and there's, and then they go wander around, right? Like kids, explore and come back to the secure base, right? Explore and attach. The ambivalent, resistant attachment, they're clingy. They don't want to leave the mom. You know, like attachment anxiety. I don't want to go to school, I want to just be with her, right? This is preoccupied attachment, when you think about it later in life. Inconsistent and insensitive parenting. So one day mom is nice and warm and loving, but the next day she's high on meth, and she doesn't talk to the child for days. It's inconsistent. And then the child has to up it, so then I think the child can't reason, oh, well, this makes sense, she's on meth, tomorrow she will be fine, right? So the child can't reason like that. So the child then creates a strategy. Now if I up it, and if I cling to the mom more intensely, then the mom will not leave me. Do you see how this child develops this, you know? And later in life, preoccupied attachment. And this is like the dependent personality, the histrionic personality disorder. Those are the ones who cling to you, you know, and don't want to let you go. Avoidant attachment is on later dismissing. Parents were distant, but consistently distant and aloof. Or intrusive and overstimulate the kid. You know, saying, oh, you know what, let me do this for you. No, let me this. And then they kind of go away and cannot stand that much closeness. And so they explore, but they don't want to go and have a connection to the parent. And then the final one is the disorganized, disoriented attachment, abusive parenting, or unresolved abuse and caretaker. So often there's this transgenerational pattern of abuse from one family to the next. And that's the push and pull we often see in borderline personality disorder. That they want, oh, I want to be close to you, but then they feel like freaked out because they can't trust you, and then they pull away from you. So this is the disorganized attachment. This is the model for attachment later in life. And model of self is like positive is secure. Positive is also when it comes to dismissing. They see, I'm fine, but the rest sucks. The rest of the world is bad, but I'm good. So they have low anxiety here. Other people are bad, and I can't rely on other people. I have to do it myself, right? Because I have learned to rely on myself. Oftentimes clients, you know what? I've always been by myself. I never had anybody. I was raised by the state. I will just take care of myself. Those are dismissing style. Then preoccupied, negative model of self, positive self of other. Therefore they cling onto other people. And the last one, both negative. You can see it is the most severe attachment. And it's not a consistent style. Here are some screening questions. You can go, if you want to look at this later. Style C, I'm uncomfortable getting close to it, I'm going to go there. So this just kind of illustrates what each style looks like in your client. So maybe, let's talk about the neuropsychology of insecure attachment. So what does it do in your brain when you're insecurely attached? And first of all, for normal, what I mean by normal, secure attachment to occur, the orbitofrontal cortex, OC, has to be engaged. It means that the secure attachment to a caregiver, meaning the mother, can be the father, can be the grandmother, grandfather, provides the self-regulation and produces empathy and compassion. So we're learning through mirror neurons, and through this OFC, orbitofrontal cortex, we learn compassion, empathy from our caregivers. So in the absence of secure attachment, we struggle with compassion and empathy, and therefore we see a lot of people who have insecure attachment being narcissistic, borderline personality disorder, histrionic, just take care of themselves, because they have not experienced this kind of positive mirroring that securely attached children experience. And this is also later in life, this warmth and loving experience between husband and wife, or between friends. They don't have this experience. We experience this maybe because we are securely attached, but they don't experience it. They can't imagine. So this is our population basically that needs to be reintegrated. Then, as a result, insecure attachment, again, empathy and compassion, there are problems with empathy and compassion, but also processing of socio-emotional information. So everything that's kind of interpersonal is very difficult for them. Modulating emotions such as shame, rage, and excitement, elation, disgust is hard to modulate or regulate. And they also struggle then, if they struggle with empathy and compassion, we'll talk about forgiveness later, then they also struggle with forgiveness too. So if a Christian, this person went through phase 1 and 2, we'll talk about in a minute, and went through DBT, can regulate her emotions, his emotions very well, but has a hard time forgiving because they struggle with empathy and compassion, and this is the key for forgiveness. So we have to assist them in phase 3 work. Some of the core beliefs, and only 4 of those, are associated with trauma. This is by Young, the schema-based treatment. Those of you who know about this. The first is abandonment, and oftentimes we think of borderline personality disorder, right? You feel like, oh, everybody's abandoning me, but it doesn't have to be only borderline personality disorder. It can be anybody who's traumatized under Herman's complex trauma disorder categorization. So they believe that anyone who's close will eventually leave me. And this is their template because this was done to them. The parent, the dad, there were 5 stepdads, mom raised him or her until age 5, then went to foster parents, and then was adopted but didn't work out. Then the state took over again, you know what I'm saying? So everybody would just leave, you know? So it's the template. So if they left, then everybody else would leave in life. So as a counselor or a pastor, we have to reassure them, no, I'm staying with you, you know, and you know what, nobody else, not everybody will leave you, and definitely God will never leave you. We can reinforce it as well. Emotional deprivation, client believes that his or her important needs will not be met by others. So again, this is also learned in childhood by parents, right? So they're not supportive, so I have to rely on myself, right? Dismissing attachment. But to remind the client, there are some people who care about client. I care as a pastor, I care as a therapist. And although no one can fully understand you, there are people who try to understand the best we can, right? We don't have to say, oh, I will never leave you, whatever we don't have to do, but we can do the best we can. And God will meet all of your needs. Not once, but all your needs. We can also mention that too. Then 2 more, and then go to the treatment model. Mistrust, belief that others cannot be trusted, and that others will eventually take advantage and abuse client in some way. Remind, they expect to be abused. Don't remind them, although he or she was hurt in the past, not everyone is out to get the client. This is kind of hard to hear for them and hard to internalize, because when you just say it, it may not stick, right? So they have to experience it over time to believe it. Makes sense? So CBT may not work alone. Does make sense? It's something that Tim alluded to this morning, right? And then we can say, you know what? It sounds like your friend Jack, he has been with you all this time, right? He hasn't left you, and he hasn't hurt you, right? So you can say that, you know what I'm saying? Or this person has not intentionally hurt a client, like someone like road rage, oh, he cut me off on purpose, right? Road rage in Minnesota is terrible, right? It's like people driving, like, and then they having those sign language and stuff. They don't understand. And so because people attribute intentionality, right? They think, oh, he did it on purpose, right? This is how we think that we get angry up on the street, right? Because we attribute intentionality, right? He did it on purpose, not because it's a bad drive. He was looking for a candy, right? And then swerving around looking for his candy that he lost, and he's a bad driver, but it doesn't mean that he did it on purpose, right? But he gets so angry. But you can imagine, this is the person who is traumatized thinks that they always do it on purpose. And so we have to help them to change their thinking about it. And then there's the one, vulnerability to harm. Believe that client is always on the verge of experiencing a major random catastrophe. This is very much, that's the hypervigilance that Hector was alluding to, that always expecting the worst, always expecting to be hurt, and always, even if things go well, something will happen next week. And I can relate to this because although my childhood was relatively, securely attached, but my mom died early, but we have a son who has special needs. And this was like traumatizing for us, financially, and of course the whole care. My wife having to quit her job and going to Mayo Clinic a lot and everything. And so now that things are going well, I myself say, you know what will happen next? And I'm not even complex trauma, but if I feel this way, I can imagine how somebody feels and thinks if this person experienced trauma all of his life. You know what I'm saying? So the question can be posed, so how do we conceptualize treatment? Phase 1, safety and stabilization. We make sure people are safe and stable. So we can't just expose them to trauma without providing some coping skills like DBT and so on. We'll go over it. Then phase 2 is trauma processing, and we talk about the trauma. And then the phase 3, we'll focus on that, is consolidation and reconnection. Let's briefly talk about phase 1, non-judgmental, balance warmth and limits, boundaries, pastoral care. Again, this is more for pastors here. If clients in counseling, DBT, CBT, reinforce effective coping, and so on. Teach Christian meditation, Jesus prayer, Lectio Divina, all this stuff that Tim was talking about this morning, we can do in this stage to basically to help him or her relax more, learn, stabilize, so he or she is not over-aroused, or under-aroused for that matter. And phase 2, this is not the focus on for today, trauma-focused CBT. You have Stacy here, right? You're trained in this. Trauma-focused CBT, exposure therapy, EMDR, Christian inner healing approaches. This is basically a Christian exposure therapy when you think about it. Theophaustic, I went to a theophaustic workshop back in Virginia about 15 years ago. So prayer. This is something that is a phase 2 work, And it's my caution is always, if this person has complex PTSD or complex trauma and is not stable, and we do those as a non-professional, then my concern is oftentimes the person may be triggered and go to the hospital. Does that make sense? We make sure that phase 1 first. Does that make sense? And of course, if someone has just simple PTSD, maybe had a car accident, and then we asked Jesus to talk to this person and has had a good secure attachment before, may not be as bad. But just be careful with the complex trauma. Let's focus on phase 3. Consolidation and reconnection. And this is after several months of counseling. This person is stable right now, has gone through DMDR or trauma-focused CBT, and is basically able to move on. So major symptoms are alleviated, but clients need to find a self post-trauma. So although some of it is being worked on during DBT maybe, with CBT, looking at some core beliefs, but still, we need to kind of do more work in this area. We need to connect to others and develop relationships in the community. We need premarital preparation or marital enrichment or counseling. We need to help to get closer to God. We need to help to forgive perpetrator. So this is something we can do as a pastor or as a clinician to help them in phase 3. This is what Herman says, and this kind of illustrates what we're doing in phase 3. Helplessness and isolation are the core experiences of trauma. Empowerment and reconnection are the core experiences of recovery. So this is something what we're trying to do. We'd like to empower them. We'd like to help them to reconnect to the community. Reconciling with oneself. So oftentimes people had dreams when they were younger. Oh, I want to be a movie star. I want to be whatever. I want to be a teacher. But then trauma happens, right? Dad dies, and then mom remarries. Stepdad abusive, and mom dies later, and so dreams are shattered, right? This little girl wants to be a teacher, can't be a teacher anymore. But then after phase 1 and 2, and this person is still young enough to go to college, maybe go and talk about this again, you know? What are your dreams, you know? Because when you have PTSD, even a simple PTSD, but definitely a complex PTSD, then you don't have any cognitive space to talk about or to think about fantasies they want to do, imagination. You just focus on the replaying of tapes, of traumatic tapes, and make sure that you're not freaking out. Make sure that you can eat. Make sure that you just make it for the day. You know what I'm saying? So you don't have any capacity for that. But after phase 1 and 2, you do. So in phase 3, we can help them to kind of get there and empower them to achieve their dreams. And which also requires them to develop a self, and this is not, hopefully, I'm not saying this is all they do, but healthy assertiveness. Oftentimes they struggle with assertiveness because if I'm assertive, then I get hurt and get beaten up. So to kind of empower them, you know what, you can be assertive, and nothing will happen to you. Actually, you have to tell a quick story about this, but most of the time, if you're with stable people and you're assertive and they love you, in a church somewhere, and not all church people are healthy, right? But most of the time, right? So you can be assertive, but you need to kind of help them to be assertive. Not passive aggressive, not aggressive or passive, right? So there's a story, this client learned assertiveness. Wow, I can assertive, and there was someone on the bus, played loud music, and he said, please, can you turn down your music, it's too loud for me. And he did a few times, and he was respectful, but he got punched in the face. So in this case, it's maybe not good to do always discern when you should be assertive, right? So maybe not on the bus when you're riding at 11 o'clock at night, you know what I'm saying? Maybe try it. But at least he was trying, he's practicing his assertiveness. So phase 3 also includes the capacity to build trust again. And I often use trust on a continuum from 1 to 10. It's like, okay, right now, how much do you trust your mom? Oh, it's like a 2. How much do you trust me right now? Or like a 4. As opposed to all or nothing. That's really helpful for them because trust is not a dichotomous variable. It's a continuous variable. When you think about it, you don't even trust everybody 100%. Would you say, right? You trust maybe your doctor. You trust maybe your mom or dad, maybe not, or you trust your spouse, hopefully, right? But again, it's the different numbers, so it's helpful for them to scale it for you. And there may be some dependency-independency issues regarding friendships. You may be too clingy or too independent. You're not going to oscillate between dependency-independency. We have to help them to be interdependent. We'll talk about it in a few minutes. And it's the same in the church or employment. They may not be, oh, I now have to work, I have to reprove myself, I have to work 50 hours, I can't say no, because if I say no, then everybody will think that I'm not competent, right? No, you can set limits, work-life balance, right? You can do that. Just a question, you can just raise your hand if you want something, interrupt. Then reconnecting with others, continue, marital relationships, reducing aggressiveness and passivity. Of course, our assumption is phase 1 work has already prepared this person to be more stable. But there is still some time when the aggressiveness reoccurs, right? It comes back, especially in a more intimate context, such as a romantic partner, right? So we're helping this person to be assertive and not passive or passive-aggressive. then spouses needs to become healthier too. So again, talk about this in a personal puzzle piece. You have this really passive person who is like this dependent personality, you know, and she marries this guy who's very assertive, a little narcissistic. The narcissistic person and dependent personality is perfect and a personal fit, you know. And now she becomes assertive. She tells him, no, I'm not doing this anymore, this is fine. And then he kind of freaks out because he can't handle it. So then they need kind of some counseling to kind of adjust, and he needs to grow with her then, basically. Or it may not work out. I'm not saying that we are, you know, saying they should get divorced, but, you know, what I'm saying, it may not fit anymore, the puzzle piece, right? Because she has adjusted and modified her, even her personal style. And again, towards independence, parenting. Children may not be used to a newly increased attention. Before she was smoking dope all day, and now she's, you know, she's good. Kids were giving back to her. They were with grandma all this time. But now the kids, my goodness, who's mom? I'm not used to this. And now mom pays attention. She loves me, and she says she loves me. Never experienced this before. She may need some help with parenting. Family of origin work, maybe helping to set boundaries. The family of origin may be really toxic, so maybe empower them to say, you know what, it's okay to not see your mom and dad for a while until they're, you know, until you're stronger and until they, you know, are no longer hurting you verbally. You know, maybe they're kind of really traumatizing you, especially when it comes to the attachment style. And this also preparing for reconciliation if it's appropriate.
So are you gonna talk at all about guilt
Guilt for
related to family of origin?
you can.
The suggestion to, you know, well, don't see them for a while gets laden with all sorts of guilt, and that leads them to go see them even when
The guilt induced by the parents, you mean, or guilt for themselves, or both?
Yes.
Yes. Yes. I mean, oftentimes with Christians especially, it's helpful to say, you know what, because they have to, you're right, that's a good point. They may say, oh no, they're my blood, right? I need to see them, right? I can't just not go, you know, but every time I go, they yell at me and are critical, you know, and then they kind of, I help, you know what, maybe for now, maybe God has a different family for you, maybe the church, maybe, you know, your mentor at Teen Challenge or somebody, you know, who can be a more positive, you know, a caregiver for you, or than that, a caregiver attachment figure, that they're saying. So, and to help them to see, you know what, maybe seeing the family a little bit broader, not just the blood family, but the family of God. Maybe, did they answer, you know, but maybe, what do you have any insights, Stacey?
No, I asked the question because I actually have a client we're kind of doing some of this, and the guilt is such a driver of their emotion related to not feeling worthy. Not like, you know, if I set that boundary, you know, I'm a bad person for setting that boundary. If I say I'm not going to go see you until, you know, for a while, man, there's that, you know, and this is like 40 years of underlying responsibility that this person has had for her family and their emotional state and ability to be taken care of and things like that.
So they took care of the family, and they were the people who basically were in charge of yeah. So
the youngest child taking care of mom and sibling.
Okay, so in this case, my assumption is that this is like more like a preoccupied attachment style, and like they're parentified. Right?
Very much so.
Basically,
Yeah, very
they're
much so.
parentified, and they had to basically then, you know, and in this case especially, then in this case I would ask about, is it true guilt or false guilt?
Right.
Because I just had a client just recently, and she felt like, oh, you know, my husband beat me up, and I feel really bad. I feel guilty that I couldn't do a better job protecting my son, so he wasn't exposed to it. I said, whose fault is it? Your husband, or is it your fault? Do you think it's false guilt or the true guilt? So, oh, you're right. It's actually false guilt. And she's in phase 3, by the way.
Yeah.
But in phase 2, she couldn't have done it. So this maybe is something, an angle you could try. Is it true guilt or false guilt? Because my guess it's false guilt, and it's like a continued tape that's not really working for her.
Right.
Does anybody else have a good idea when it comes to guilt? Okay.
Well, one of the things that might be helpful too is just participation in a small group. I mean, I think about Bible studies and stuff like that at church, and having people around you who, while you're recalibrating it to a more appropriate understanding, have people around you who understand your journey in that, who can be with you like a cast while you're forming a new bone. So.
It has actually been really helpful to be involved in a faith-based community for her, because she's actually discovering her faith, but now understanding faith comes with a whole list of responsibilities that she's failing at, and now she feels guilty for not being a good enough person, because there's this just that pattern of not being good enough or faith, guilt. So, and I've been pushing her that, like, absolutely. But
yeah, it sounds like she's a very guilt-prone individual and stuff. And,
Yeah.
and my guess is that most of it's false guilt.
Oh,
Not
for
that you
sure,
would say
for
it
sure.
bluntly to
Yeah.
her, but you would kind of slowly show her that guilt is good. And and there was something on the slide. Guilt is still okay. I mean, as Christian counselors, I think we should always kind of, in my opinion, you don't have to agree with me. Guilt is something that it's a good emotion. It's like you feel bad about that I hurt you, right? Guilt is not bad, right? Because otherwise, how can the Holy Spirit correct us if we don't feel convicted and guilty, right? We think about it. So if everything is we just therapize guilt away, then we are like little Christian sociopaths and stuff. You know what I'm saying, right? Right? Does it make sense? But shame is bad. So I feel bad about myself, then that's bad, God doesn't want it. But guilt, I feel bad about my behavior, then that's okay. But in this case, false guilt, so it sounds like, right?
I like that language, false guilt, real guilt.
Yeah, so there maybe. So, object relations, those of you like it, Fairbairn, he's like the father of object relations, and Bowen, family systems, drew a lot from object relations, and so for him, emotional maturity, that roughly, and it's really simple. I'm not that smart, so I like simple outlines. I like those 3 words, it's good enough for me. So dependence is like a child, right? So the child is dependent and needs to learn independence, right? But then later, in order to be fully mature, we need to be interdependent. And this is not just for our clients, also for us, right? And we'll talk about it in a few minutes. Because we as therapists, we also have attachment styles too. And we bring those attachment styles into our counseling room, So if you are have a dismissing attachment style, we may just stay on a cerebral level and just talk about, this is not really whatever. And if you're preoccupied, we just cry at a client, hold hands, hug all day and stuff, nothing, of course with boundaries, But I'm just saying, so we have to be secure too, you know what I'm saying, right? So this is also for us like an encouragement to seek maturity with God's help, interdependence, and so just want to put this out. This is what the client needs to learn: interdependence. And how does it look like? Bowen, and this is from Steinke, and I liked how he put it. Like this is how interdependence, and Bowen called it differentiation from your family. Those of you who have family systems, family therapists, Bowen, right? But this is actually more like an object relations concept. Having an I and entering a relationship with one another I, without losing yourself or diminishing the self of the other. This is true interdependency or differentiation. Defining yourself and staying in touch with others. Being responsible for yourself and responsive to others. Maintaining your integrity and well-being without intruding on that of others. And finally, allowing the enhancement of the other's integrity and well-being without feeling abandoned, inferior, or less of self. So this is our goal, and I'm sure most of you all here are there already, but God have helped me a lot during my internship not to be like more interdependent there, and I was more like that I'm more the dismissive kind of cerebral type, and my wife and God has helped me. So that's good. God bless my wife. So this is like, and basically we need to model for our client the balance between emotional distance and emotional fusion. And again, we see the attachment style again. The emotional distance is the dismissing style, and the emotional fusion is a preoccupied attachment style. And then we have on top the secure style. We could hypothesize, or not so much hypothesize, that the disorganized, the most severe style is alternating between the two, oscillating. Right? And therefore you see this pull and push, when you think about it. And so we definitely need stability. But again, we're talking about phase 3 right now, so our assumption is that this person is kind of pretty stable when it comes to affect and mood, but still maybe struggles to find earned attachment. This is basically what we need. If we don't have secure attachment, we can, this is the good news for everybody, and this also legitimizes counseling, because if you don't have secure attachment, you can earn it later. Through counseling, through God, God can help you to achieve earned attachment. Earned security, earned secure attachment. We see interdependence in the church too. Hopefully I don't do eisegesis and read into it, but correct me if I'm wrong. We have pastors here, so correct me, it's fine. The body is not one part, but many parts. If the foot should say, I'm not a part of the body because I'm not a hand, that would not stop it from being a part of the body. If the ear should say, I'm not a part of the body because I'm not the eye, that would not stop it from being a part of the body. If the whole body were an eye, how would it hear? If the whole body were an ear, how would it smell? The eye cannot say to the hand, I do not need you. Or the head cannot say to the feet, I do not need you. Some of the parts we think are weak and not important are very important. If one part of the body suffers, all the other parts suffer with it. If one part is given special care, the other parts are happy. You see this interdependency here? It's not dependency, it's interdependency. It's basically, and this is I guess what also the early church was all about. In our Western, not just US, but also European church culture, we are very individualistic. We tend to be more independent, but not interdependent. It's just my bias and stuff. We have not, unless we have minorities have an advantage. African American, Hispanic American, Native American, they have it much better with independency than Anglo Americans. So, generally speaking, you know what I'm saying? So, depending on. So, reconnecting with God to continue on. So, we got this. We need to help this client with interdependency, with differentiation. And this is kind of like an ongoing process. But also, now reconnecting with God, God image is distorted from trauma and or insecure attachment, so we can use religious imagery. Like now an experiment for you, could you all close your eyes if you want to participate? Free country, you don't have to. Just eat a cookie or something. And just picture, you know, before you do this, take some deep breaths in through your nose, exhale through your mouth. And just picture Jesus just hugging you. Just focusing and he's listening to you. And he sits there and he listens to you, what you have to say. And he's supportive to you, doesn't interrupt you. And then he holds your hand. How was that for you, if you don't mind me asking? What did you experience during this religious imagery? Relaxing. I think in your case, I'm assuming you're all pretty securely attached, you know. But again, this may be something that you could try with someone who has a negative God image, but the risk may be that this person cannot produce it, right? Because this person doesn't have the template to. Go ahead. You had a question?
Yeah, I was just thinking about this in the attachment theory. If you can visualize the cross, you have one going up vertically, you have the other extension horizontally. Well, if the individual, the counselor, the therapist, or the person is not connected vertically, then he or she is not receiving anything vertically from the Father.
Yes.
Therefore, that vessel is primarily empty in order to be able to release something horizontally to a patient or client.
But it's connected, right? So it's not.
Yes.
Good point. Yes, exactly. That's a good imagery that you mentioned. Yes, and like when Jesus said, "Love others as you love yourself," and love God with all the hearts and mind and soul. And some theologians say this is the core of sanctification, right? If you can those two, then you're right. This is so. Yeah.
Actually, too, I was thinking about how the actual genesis of the attachment theory actually goes back to Genesis, when Adam and he was, both of them were in a secure place until they became, until they disobeyed the command, and then they found themselves from step 1 secure down to step 4 disorganized, fearful.
Yes, and shame.
They were totally
And
attached.
shame, right? Because every insecure attachment produces shame, right?
Right.
And shame is like, I'm not good enough, I'm not guilt, shame, right? So, very good, that's good point. Here, similar to what we saw before, but just applied to God image. So they did a study, like, and they published it in 2003, and you see the similarities, like the secure has like a model of self and model of others positive, and we just read in the middle the God image part. Positive view of God, and they perceive God is available and supportive. And again, it's pretty much in line with what they experienced from their caregivers, right? The template is basically secure, and so they expect God to be there for them. Then look at the preoccupied. Positive view of God, but ambivalent about availability and support. They say, oh, God is great, but I'm not sure really if He's there for me. Maybe He's there for other people, but not for me. Have you heard this before? Right? So, because the parent was not always there consistently, right, for the client. So then God is similar, and maybe perceived as being similar to the parent. Dismissing positive view of God, and God is available and supportive. This is based on a study, but my critique is, those are the people, by the way, like, I am Jesus, I don't need church, I can watch TBN on Sundays, I don't need anybody because they're all hypocrites in church, you know? Right, those are the people to dismiss, you know, right? So, I don't need anybody, I just need God, only Jesus, right, nobody else, those are dismissing. But I question if they really have a truly positive view of God, or if they're not really aware when they did the study. Does that make sense? That's my critique of it. So my guess is that they have a hard time trusting God too, but they would not maybe admit to themselves that, oh, I don't see God negatively. Does that make sense? They're too defensive maybe. That's just my opinion. And then the fearful, which is disorganized type, negative view of God, and no availability of support. So they see God as harsh as a dictator, and there's no support for me. So this is the most severe. Jump in anytime. Then forgiving the perpetrator. Let's talk about forgiving. If you missed Russ Berg's presentation, you get some little forgiveness lecture here too, in the grade 2 for Nazis. So that's awesome. So just a little, just the main points of what forgiveness. So be cautious, do not push client to confront the perpetrator and to reconcile. So for instance, again, we have done phase 1 work, phase 2 work, the person is stable, but then there's still the uncle is the perpetrator, and it would be a mistake to say, you know what, you should go to your uncle and just tell him how much you hurt him. How much he hurt you. So that's kind of really dangerous, even at this point, because you don't know how this person, I'm saying the uncle, would react to the client. So that's pretty. Would you agree? So unless it's a controlled situation, I do like sex offender treatment part-time on the side, and if it's a sexual perpetration, sexual offense, we would only do it if you do like an official reunification session where the perpetrator has received sex offender treatment, is truly accountable for the offense, and has gone through treatment, completed it, and the person who's the victim is really stable, gone through phase 1 and 2 and is willing and able to reconcile and reunify with the perpetrator, right? But similar to any other offenses, perpetration, so like physical abuse, emotional abuse, similar too. If the uncle is still really harsh and blames the victim still, then it's not really helpful for her or him to confront the uncle. Would you agree? So in this case, you can do something therapeutic, like write a letter and express your anger towards your, and you don't stay there forever, right? Maybe express your anger or your questions that you have about the abuse to your uncle, and read this in our session next time. We process together. Or do a Gestalt technique, right? The empty chair, right? Those of you who know what, we can do that there too. So, but again, this is the difference between forgiveness and reconciliation. Oftentimes in the church we say you should forgive, and then it kind of just coincides with reconciliation. Again, going back to the uncle situation, the uncle was abusive to the client, and pastor says you should forgive and go over there and be friends again. But what if the uncle is still abusive and re-victimizes the client? So therefore it's helpful to differentiate, according to Worthington, between forgiveness and reconciliation. This little joke there, can you read it? This is Jesus. I tell you, not seven times, but 77 times. And the disciples say, great, not only do I have to forgive my brother now, I have to do math. Back then they didn't have calculators. So it was hard. So interpersonal forgiveness and God's expectation. What really helped me recently was this book that Worthington wrote in 2009. And you don't have to agree with him, that's fine, but it helped me. It was God requires decisional forgiveness, but God desires emotional forgiveness. So he defines decisional forgiveness as you basically abstain from acting violently or rageful towards the perpetrator in revenge. So you're not beating this person up, you're not doing anything to harm the person. Like back in the old days, remember in the Old Testament it talked about having the cities for the one who was incidentally killed. Remember that? Mm-hmm. And because it was a very hot-headed culture back then, right? And so even the ones, sorry, I killed your mother. So that's okay. It's fine. And then there will be, I kill you now too, right? Because you killed my mother, or killed my ox, so I kill your ox and stuff, right? And so they had those refuge cities, right? To make sure, to ensure that the person who accidentally killed the person is safe, right? And so therefore, decisional forgiveness is not acting on these impulses and not doing anything. But emotional forgiveness is a step further. This is like you're experiencing an emotional replacement of negative emotions. So you're actually letting it go and you truly forgive. And this is only possible with empathy and compassion, which the Holy Spirit can help us with. This activates mercy and grace motives. And the example is the prodigal son in Luke 15. So according to Worthington, he defines forgiveness as a motivation to reduce your withdrawal or avoidance of the person, reduce your desire to seek revenge or get back at the person, and increase your efforts at reconciliation. So once you forgive, then reconciliation is more possible. But of course we still have to kind of make sure that person is safe. Quickly, forgiveness is not condoning or excusing, justification, forgetting, self-centering, letting time to heal. We all know this maybe, but definitely it's not reconciliation, because as he defines reconciliation, it's the restoration of trust in a relationship in which trust has been damaged through mutually trustworthy behavior. So this is the key, because if the uncle can't be trusted, then we shouldn't reconcile with the uncle. Because he has, in order to reconcile, I need to trust the uncle, and unless he demonstrates to me that he can be trusted, I don't reconcile with the uncle. So I can forgive from a distance, but I don't have to reconcile. I don't know, would you agree with that? I mean, that's basically a pretty safe thing there. And in order, how we can help the client to forgive is empathy. And often ask the clients to pray, to ask the Holy Spirit to help with empathy and compassion. And as you know, empathy is feeling with the person, putting yourself in the person's shoes, and it should develop, not should in the sense of Albert Ellis, should statements, right? But it's to be expected, maybe better, to develop into compassion, and it's separate from actions. So the homework exercise is oftentimes I assign, write a short letter expressing empathy. Put yourself in your uncle's shoes and write down what he would say about your abuse. You know, like maybe take into consideration how he was raised. Maybe he told me he had a really harsh mom and his dad was killed early. And so maybe, you know, and so maybe you can put yourself and write a letter from his perspective to you. Not to justify or condone the action or the abuse, but just to get a different perspective. So you can let it go and give him this gift of forgiveness. Make sense? We have a movie still, but I think we can't watch the whole thing. But any questions at this point? I think it took longer than I thought, but I was not.
I have just a brief comment on that forgiveness, which is a key element or key component, because if we withhold the forgiveness factor, then what happens is that the individual that we have an ought against or issue against, that person is still bound. And as a result, the person that has not forgiven is still bound.
Yes.
But until they actually forgive them, the individual is released and they themselves are released,
Exactly.
which is a key.
Right. And you don't have to agree with Worthington's differentiation between decisional forgiveness and emotional forgiveness, but I think he would agree with you too. I mean, it's like you're bound and you're basically releasing, you're making your life easier by forgiving, right?
Yes.
And so definitely. But I like how he put it, because some people, and also, it's also what's not in there, because it's not the focus was not on forgiveness. We also know it's a process, right? We can't just expect, I guess today we talk about forgiveness, so by next week, homework, you have to forgive your dad by next week. So, that was a joke. But because we know we have to work the process, right? And we have to work, and again, take into consideration the attachment dynamics, we can see why it would be so difficult for them to forgive, because the orbital frontal cortex, is basically being developed through new relationships, through the Holy Spirit. It's being changed. And so the person learns empathy and compassion slowly through the therapeutic relationship and through other healthy relationships in the church. So.
Marcus, what I find a lot working with women is there's a lot of unforgiveness towards themselves and condemnation, and I don't know, do you do meaning what you said on how to help them work through that?
I think I did a talk on forgiveness, and then I included there's a whole step of self-forgiveness too. But basically, instead of having empathy for others, there are steps to help them develop self-compassion. So basically, oftentimes say, how would you feel about if somebody did this to themselves, and they say, I think this person didn't do it on purpose, and this person was raised this way, and no wonder this person did it, right? So this person can forgive other people, but have a hard time applying it to themselves. And then you turn around and see, if you can forgive this person and can explain why this person did this, how it's very difficult, sounds like, for you to have compassion for yourself and put yourself in this person's shoes. Which makes sense. The other, so this is basically the conclusion. The next one is like a little movie, but we don't have time to watch the whole thing, but you can watch it at home with some popcorn. Right?